Hi everyone and welcome to Methylomic Matters, the podcast in which we discuss all kinds of matters regarding the Methylomic Project, a large European research project aimed at enhancing the effectiveness of the medication in chronic diseases such as Crohn's disease, rheumatoid arthritis and psoriasis. And this episode is especially made for patients with Crohn's disease. My name is Shula Tas, I'm a journalist, and in this episode we will discuss OmiCrohn. And we do that with two gastroenterologists. Next to me are Geert D'Haens, Professor of Gastroenterology at Amsterdam UMC and also project leader of Methylomic and OmiCrohn, and Marjolijn Duijvestein, gastroenterologist at the Radboud UMC in Nijmegen, which is one of the Dutch hospitals where the research is done. And also here is, last but definitely not least, Dalia de Jong, who is a patient with Crohn's. Welcome, everyone.
Thank you.
Let me start by asking the first question. What is Crohn's disease exactly, Marjolijn?
So Crohn's disease is a disease of which we not really understand what the actual cause is. But as a doctor, I see patients that have bloody diarrhea, so bloody stool, abdominal pain, they can lose weight. And when you do an endoscopy, so when you look in the intestine through the scope, this is one of the diagnostic tools that we have, you see wounds in the intestine, so you see ulceration. And this makes the patient ill.
And I can imagine it must be painful as well if you have ulcerations.
Yeah, so patients experience abdominal pain, but also symptoms such as fatigue. They can also have symptoms beyond the bowel, for example, in their joints, or skin problems, or inflammation of the eye. So it's not only the digestive tract, but more than that.
And Dalia, you have this disease. Can you explain a bit how it impacts your life?
I got diagnosed when I was 17. So at that age it was kind of difficult to hear like, okay, you have a disease and we don't know if you ever get better. Well, that was kind of hard. I had a lot of pain in my stomach and I was tired. So at least I was happy that I knew like, okay, I have this disease. They know what it is and now they can treat it. And I think in different stages of my life it had a different impact because there were periods that it went really well with my disease and I didn't feel sick at all. And now the last years, it's, so. Also, it takes like a lot of planning because every 4 weeks I have an IV and I'm traveling a lot for work. So you always have to see like, okay, can I go for work or can I travel now or do I have to reschedule the IV and stuff? So it takes a lot of planning, but also, the daily pain. It's just kind of annoying, but I guess you just learn to deal with it.
Yeah,
because I can't remember not having it anymore. So we just make the best of it.
Yeah, you adjust to it, but it impacts you in the sense that you have pain on a daily basis.
Yeah,
and you have to plan your treatment every 4 weeks.
Yes.
And you just told me you're a poker player and you travel all around the world. So that makes it a logistical challenge every once in a while. Yeah.
But for now it works. So
yeah. How is Crohn's currently treated, Geert D'Haens?
Yeah, well, I'm probably old enough to give the whole history of Crohn's disease treatments. When I started, we only had prednisone and azathioprine, really, which were okay drugs, but many patients had to take a lot of corticosteroids and had a lot of surgeries and stomas. So in the 90s, for the first time, we had a very effective treatment, and that was antibodies against TNF, a drug that is also used for rheumatoid arthritis and psoriasis. Very effective when you start using it in the first years of the disease. But unfortunately, over time, as we've heard, many patients lose response. And also a considerable proportion of patients just does not respond to this treatment. And so that's why new antibodies were developed. Then we've seen vedolizumab, ustekinumab, IL-23 antibodies, quite a few new agents. And now we know that all those agents work in 40-50% of the patients, but we don't know which agent to use first. And that's exactly what we want to sort out in this project.
And so then OmiCrohn comes into play. What is OmiCrohn? Can you explain?
So I think we discussed several things and aspects of the disease. So it's a chronic disease and nobody can predict how the disease course will be in the individual patient. And we do not know as a doctor which drug to prescribe first. So we have a lot more to choose from, as Professor D'Haens just pointed out. But at the end of the day, when I have to make a decision with my patient, I look at clinical factors. I look at the age of when the disease was diagnosed, if patients have, for example, also rheumatoid arthritis symptoms, and then we choose together, do you want to have oral drugs or intravenous drugs or subcutaneous? We choose which product or which drug would be the best for that individual patient. But there's not more knowledge than this at this moment.
It's still trial and error.
It's trial and error, and it takes a while before you can conclude if it works or not. And we're talking about months here, so about 4 to 6 months in general. We say, okay, you have to wait to see if you have a response or not, because it takes a while for the gut to heal.
Yeah.
So in this project, we aim to predict which drug works for the individual patient. And I think with that, we can really make a big impact.
You look like you want to add.
Well, no, I think what we have developed is a kind of a predictive algorithm. So AI plays a role here based on the DNA of the individual patient that allows us to predict, okay, this drug will work with 85% likelihood in this patient, this drug will work with 60% likelihood. And in the OmiCrohn trial, we will evidently select a drug with the highest likelihood of efficacy.
So there's a lot has changed with better drugs, but it's still difficult to find the right drugs and the right medicine. And the added value is that we can help people sooner and maybe with a higher chance of being effective.
Well, exactly. If you give an ineffective drug,
yeah.
It causes not only a lot of suffering, but also complications. Patients may develop fistulas, stenosis, and surgeries. So ineffective treatment is very harmful to patients.
It's a snowball effect. So when you have the inflammation going on and going on and going on, it gets worse and worse and worse. And then, of course, you have the all the complications that were just described. So the sooner you give the right drug, you can prevent the disease to become worse.
Yeah. So this sounds very important and very promising as well, this OmiCrohn trial. How quickly do you expect this to be incorporated into the care pathway?
Well, we first need to do the trial, of course, and that always takes time. So now for all the hospitals that participate in a trial, we can immediately start, but then of course you have to find out if this really works, and that will take a couple of years before the trial ends and you do all the analysis of the data. You have to write, of course, articles, and then afterwards you can perhaps integrate it in your daily practice. So that will take a while, but for the participating centers it starts now.
It starts now. What would it mean for you, Dalia, if you could get the right medicine right away?
I think that would be amazing. I had so many different medications, and I think it would save so much time and suffering if you can see, like, okay, this is the one for you, or well, the most chance that it will work. I think that's amazing, and I would definitely be open to it to
participate.
Have you suffered complications while being on ineffective treatment?
Yes, I have.
Can you tell us a little bit about it?
Just things that just didn't work. I had I don't know the name of I only know the name of the brand, so I can't say it. But I had a lot of medication that just didn't work, or I made antibodies for it. Okay. So, and then I just got even more sick. And it was just like, okay, 5 months of trying, and then I got a new medication and it didn't work. And then, well, I came to this hospital, and now finally I have something that works. So it would have saved a lot of time to just knew before, like, okay, this is the one, and let's go for that one. And that's the biggest chance that it will work. Yeah.
Did you lose also working time? while you were sick?
I lost a lot of working time. Just stayed in the house. Actually, I was quite lucky because it was COVID peak, so didn't miss a lot. So, but yeah, it's just it takes a lot of time, and also, your life just stops at that moment. And it would be amazing if you can, just find the right treatment for every individual patient.
Yeah. So, and if you would like to participate in this study, what does it mean for patients?
If you are a patient in one of the hospitals that participate, or you can come to one of the hospitals that participate, we of course have to see if you fulfill all the inclusion criteria. So for every trial that we design, we always set up certain rules, which patients to include, which not to include, to have the group, the population, as much as the same as you would like it to be. So you first talk to one of the study nurses, and then we go through all these selection criteria. Then we withdraw blood. You have to see if there is indeed inflammation going on, so a patient has an exacerbation, so a flare of their disease. And then after the diagnostic tests are done and evaluated, we can make the prognosis which treatment the patient will fit best. And then the patient is treated with that drug. And then after 6 months, we evaluate if indeed the disease becomes less severe, or if the patient is in remission. So all of the patients are treated with the drug that fits them best when you look at the predictive values that we know now. So after patients are included for the trial, they are randomized. So that means that we look for half of the patients are treated as they normally would have treatment. So they are treated, but as standard of care, as we normally do. And the other half of the patients are given a drug fitting what the prediction says. So all of the patients are treated with a drug, and after 6 months the patients are evaluated.
Yeah, it's what we do in concrete is we take DNA from these patients, because that's really how we will determine the methylation profile, and that takes around 2 weeks. So
you draw blood?
We draw blood, and the DNA is extracted from the white blood cells. Then that isolated DNA is sent to an advanced specialized lab where they measure the methylation with a test which is called EPIC2, an Illumina test. And then we receive all that information of the methylation on 850,000 sites in the DNA. And then our computers work really hard for a couple of hours, and they generate the result based on an algorithm that we developed previously in an earlier study. And that information is immediately communicated to the hospital where the patient is treated, so the first infusion can be given. And the treatments under study are vedolizumab and ustekinumab, and both begin with an infusion, and then later followed by injections.
Yeah, so you draw blood, you take the DNA from the blood, and you put that through AI to really simplify
First
it.
a lab,
First
for
the
the
lab,
methylation, and then the artificial intelligence.
and then artificial intelligence makes the calculation into what medication would be most efficient.
Exactly.
And that's different because doctors are not able to, or people are not able to make this.
No, our brains are too small.
Yeah, our brains are too small, and AI helps us to calculate which medications will be most effective. This research takes place in 6 different countries, namely Italy, Belgium, the United Kingdom, Slovenia, the Netherlands, and Hungary. And as I understood, you can ask your treating doctor about which hospitals to contact if you would like to, or if you're interested in participating in the trial. Would you like to participate, Dalia?
Yeah, I would be definitely open to it.
Yeah.
I don't see any downsides, to be honest, only positive outcomes. The only thing is I'm trying to get pregnant now, so would that be possible in this trial?
So, as I discussed, in an exclusion criteria are there, and one of the exclusion criteria is a pregnancy wish, because a pregnancy itself can change outcomes, and we also do not want to do endoscopy during a pregnancy, so that's more difficult to plan. But hopefully in the future we can use this predictive measure anyhow. But pregnancy itself is an exclusion criteria.
But your point is well taken. There is no downside in participating. The only thing is, of course, that you need to be a bit stringent with your visits and with recording your symptoms and with undergoing the procedures. In a number of centers, there is also going to be ultrasound in addition to endoscopy, so we can rapidly see if the treatment works. But other than that, the follow-up is what you would regularly undergo. So
it doesn't really have an impact beyond the regular visits you have to make already as a patient?
No, it's just a bit more stringent because it's a clinical trial. You cannot forget too many days of completing your diary, for instance.
No.
But otherwise it's the same.
It's for a good cause. So.
Yeah, exactly. It might help lots of people. Well, let's say this works. How will it benefit patients and physicians? This OmiCrohn. Let's say it's successful. We look back on it in a couple of years. What will it look like?
If this works, then we can easier predict which drug works better or best for your individual patient. So you treat the disease quicker, so you have less complications. Patients can go back to normal life, less work loss. Less social contact loss. Many patients have less quality of life. And at the end, of course, this enhances outcomes. Of course, this is also something that's really nice for insurance companies, for the government, for everyone. So hopefully by treating patients, we can make the impact of the disease much lesser.
So it's win-win-win.
Yeah, already we are seeing fewer complications by Crohn's disease in terms of hospitalizations and so it's much less than 20, 30 years ago because of the more potent drugs that we have. So this is a next level. Yeah. This is again an added level of advanced care, which is, by the way, standard in oncology. If you have a tumor, they measure the DNA of your tumor and they decide which treatment you need. So we're a bit behind in Crohn's disease and inflammatory diseases, but we'll catch up.
Yeah, because it in oncology it's called personalized medicine. What else can we expect from personalized medicine?
Well, perhaps we can even prevent the disease in the first place. So we're just at the beginning, and I think there's so much more ahead of us.
That sounds very promising. Thank you all for coming here, and thank you for listening. For more information about participating, please visit methylomic.eu or find your national patient association.